Everyone for joining us for our latest media briefing on important healthcare issues in the news. It's clear you care and we care deeply about our healthcare system, and that's why we're all here today. I'm Dr. Dominik Nowak. I'm a family doctor in Toronto, and I'm also president at the Ontario Medical Association. This is the voice of 43,000 doctors in Ontario. We're here today to launch our Stop the Crisis campaign and lay out our advocacy priorities for coming months to get our healthcare system back on track. The term crisis is any event or period that leads to an unstable or dangerous situation affecting an individual, group, or all of society. And it's become so clear that our healthcare system is in crisis. More than 2.5 million people in Ontario are without a family doctor, and in less than 2 years, that number is going to almost double to 4.4 million. Emergency departments are crowded, and in many communities, they're struggling just to stay open. Patients still have to wait too long for appointments, tests, and care, up to the point that it's become dangerous for many folks as they wait and linger languishing on wait lists. Individually, any of these issues would be considered a crisis, and together we know they represent a catastrophe facing Ontario in our healthcare system. We can change the situation, and we have to change it. Ontarians deserve better, and this plan outlines immediate steps the government must take to stop the crisis. So now I'd like to introduce some of today's panelists. We'll speak about the recommendations in more detail, share their insights on the crisis we face as people living in Ontario and as health professionals and doctors, and look at how do we get things back on track. Dr. Audrey Karlinsky is a full-scope family medicine physician. She's also an assistant professor of family and community medicine at the University of Toronto. Dr. Andrew Park is the immediate past president at the Ontario Medical Association and an emergency physician at London Health Sciences. Dr. Sarah Newbery is a rural generalist and assistant dean of physician workforce strategy at the Northern Ontario School of Medicine University. Now we're going to start with Dr. Karlinsky, who will tell us about her experiences as a family physician on the front lines and explain why the OMA is urging action on the crisis in primary care. Over to you, Audrey.
Thanks so much, Dominik, for your introductory remarks. The crisis is very real, and as the media in attendance here can possibly tell, I've been at this work for close to 40 years. And in that time, I've had the privilege of looking after thousands of patients, delivering thousands of babies, 2 generations. I've been privileged to teach the next generation of family physicians. And I'm bereft. Every day I look around and see that there is no succession planning because the number of medical graduates who want to do this work is declining year over year over year. This is good work, and we ought to be able to have conditions that are encouraging our best and our brightest to take on full scope longitudinal family medicine. And the reason that we're not able to attract and retain is because of inflationary fee increases, the burden of running small businesses, and the very, very real downloading of work onto our family physician workforce all across the province. And so it's heartbreaking day after day, getting phone calls from potential patients, begging most of the time to be added to our patient rosters. And it can't be done. There is just no capacity in the system. What we need are teams. I need to be unburdened from the 19 plus hours a week of unnecessary paperwork that I'm doing. Being a data entry clerk and managing this is not a good use of my time. Those 19 hours could be parceled out to allow me to work top of scope, which is seeing more patients, adding more patients to the rosters that we carry. But I need to be able to pay a good and living wage to staff so that this is a profession, so that I can offer pension and benefits like the hospitals are able to do. And there's just no opportunity to compete with that. And so we hire, we train, and we lose staff year over year over year. It's exhausting, and it's exhausting to have 24/7 need of reviewing information that's coming all of the time at us through our EMR, our electronic medical record, to manage patient care. Yes, your life is our life's work, and we value that and we want to do that. But I need a team. I need it urgently. And I need the ability to show my trainees that this is great work, once again, worthy of their consideration.
Thank you, Dr. Karlinsky. I'll now turn things over to Dr. Park.
Hi, everyone. It's great to be back speaking to the media again. I'm speaking as both the immediate past president, but also as an emergency physician who's been practicing for 17 years. And I think we all know the why it's important to keep emergency departments open. If you or your loved one is having an emergency, you think you're having a heart attack, obviously accessing care is going to be one of the most important things you can do. And that's why it's so concerning to me that between July of 2022 and June of 2023, we had closures of our emergency departments across the province over 200 times. That's both highly concerning and unprecedented. And the way I see emergency departments is that they act as a proxy or a pressure gauge, a proxy pressure gauge or valve for the entire system. So when we see failures in the system, we see them in the emergency department because where we sit physically and figuratively is both at the crux of outpatient management, clinics, physicians, as well as patients who are unattached. We sit between them and the acute care. So we see all comers that come into the emergency department. So I want to talk a little bit about the front door of the emergency department. And what I've noticed, so I took a year off to do to be the president of the OMA. So it was a year sabbatical, and I came back in May. And over the past 5 months, I'm looking around my emergency department, and I noticed, wow, the complexity of patients that I'm seeing is extraordinary. I've never seen this in my 17-year career. So I said, well, maybe it's me. You know, I had a year off, and so I started calling colleagues around the province just to see, you know, are you noticing the same thing? And the short answer is absolutely. We're all noticing the same thing. There's an incredible and a dramatic uptick in complexity, which acts almost as our new acuity because it takes an immense amount of resources to manage patients that are more complex. But our resources haven't changed, right? So we're resource constrained, our needs are higher. And what this reinforces is what the pandemic reinforced to me when I was president and what we've been saying for at least a couple of decades. And as my colleague, Dr. Karlinsky has said, and I'm sure as Dr. Newbery is going to reaffirm here, but that those without a family doctor do worse. They're sicker, their diseases present later, and they place an inordinate amount of pressure on an already pressurized system. And that's what we're observing right now. And so those are the patients that can't access a family doctor, and they're coming to us for cancer diagnoses in an emergency department. I can't imagine what could be more awful than that, let alone in an emergency department. Right? On the other end of the spectrum, we're also seeing patients who have minor needs and they need to see a doctor. And there's only one place in our system where you can go 24/7, no patient caps. Whatever your needs are, you will be seen in an emergency department. And the issue is that they're saying, I can't get a family doctor to take care of these things that I know I don't want to be here for. So they're willing to wait 3, 4, 5, 6, 7, even more than that in hours just to see a family doctor to do something that they know that they don't need to be in an emergency department, but have few or little options otherwise. I also want to talk about the back door of the emergency department because that's where we also see major issues. We have patients in a hospital that don't need to be in a hospital, don't want to be in a hospital, and do worse in a hospital. They don't need the acute care facility that they're being placed in, but they have no options otherwise. Either they want to be at home and need home care to help support them, or they need supported housing in one way or another. and that's not available. So what happens is that creates a bottleneck that is the hospital that just creates a logjam going back right into the front door. I've worked in departments where I, as an emergency physician, can't physically see my patients that are waiting to come into the department because of the logjam in the back door. So both of those doors really need to be addressed, and we need to look at the system overall as to how, the solutions that we have and the different tactics that we want to bring to government to say, look, these are the solutions that we have to fix what is really an ailing system right now. Dr. Nowak.
Thank you, Dr. Park. Now I'd like to turn things over to Dr. Sarah Newbery.
Thank you so much, Dr. Nowak. I want to begin by just saying that it's such a pleasure to be able to join you here in this setting today from the community of Marathon, which is located on the north shore of Lake Superior in the traditional and unceded territory of the Ojibwe people of Bigtugong First Nation. And I have had the privilege of living and working here for the past 28 years. I want to begin my remarks by really reminding us about the context of Northern Ontario. Northern Ontario is a vast geography. It is the size of France and Germany combined. It is 25% larger than the state of Texas. If you start in Kenora on the western edge of Northern Ontario and drive to Temiskaming Shores on the eastern edge of Northern Ontario, you will drive 1,600 kilometers. If you start in Kenora and instead drove those same 1,600 kilometers west, you would find yourself in Edmonton. Northern Ontario, in fact, spans a geography that is the equivalent almost of 3 entire Western provinces. And we have a population here of roughly 850,000 people. That's less than the population of the city of Ottawa. We have only 5 urban sites. Only 2 of those urban sites in this geography have a population of just over 100,000 people. They are roughly the equivalent of the size of the city of Guelph. And really the majority of people in Ontario don't see Guelph as a major urban center. Delivering care here is hard. Being a patient here is harder. We know that Northern Ontario citizens have worse health outcomes than those in the rest of the province. We know that their life expectancy is 2 to 2.5 years less than the provincial average. We know that doctor shortages and other staff shortages are leading to challenges of timely and equitable access to care. According to the Ontario Medical Association's Physician Resource Integrated Model, when we look at the data from 2021, we know that we delivered 600,000 fewer doctor services than would have been expected for this population, and that is largely because we don't have the doctors to deliver the services that the population expects. In June of 2023, our community recruiters all across the north provided information about the number of physicians that they were actively recruiting for, and we know that in June of 2023, across Northern Ontario, we were actively recruiting for more than 350 full-time equivalent doctors. More than 200 of those needed to be family doctors. We don't have all of the data yet for 2024, but the number has certainly trended up, and it appears now that we are actively recruiting for just over 400 physicians across Northern Ontario. That is roughly a quarter of the entire doctor workforce that works here in Northern Ontario. We know too that rural and northern municipal governments have begun to incentivize the recruitment of physicians, which really puts communities in competition directly with one another for what is a very scarce resource. But there are things that we can do to support and sustain doctors in Northern Ontario so that we can deliver the care that our patients and communities need. First, we need a northern and rural physician workforce strategy to help to coordinate the ways in which we train, retain, and recruit doctors for Northern Ontario. We recommend that the government work with the OMA to develop and implement without delay a northern physician workforce strategy, including the creation of a coordination center that can come to understand the needs of communities and also the needs of physicians in our communities, so that we can better understand what it will take to sustain and retain them in the communities of Northern Ontario. This would be a center that would function in a way very similar to the highly successful Rural Coordination Center in British Columbia. As part of a Northern workforce strategy, we need to pay special attention to those medical disciplines in highest demand, and those include family medicine, pediatrics, psychiatry, obstetrics or maternal health, anesthesiology, and internal medicine. Additionally, as medical schools across the province and the Northern Ontario School of Medicine University, in addition, expand the number of medical learners that we have, we need to retain a focus on doctors as teachers. We need to understand medical education as an apprenticeship, and we need doctors in all of the communities in which we need our future doctors to be able to learn and train. Second, we need to ensure that keeping services open in hospitals is as seamless as possible. And to that end, we need a regional credentialing system that will make it as easy as possible for a doctor in one community in Northern Ontario to be able to cover a shift or a service in an adjacent hospital. Removing unnecessary barriers and paperwork to being able to work across hospitals is an important initiative that will serve us well. Finally, doctors working in Northern Ontario require a broad skill set to be able to deliver care to the communities in which they work. And we need a program provincially to help support them to maintain the skills that they have and acquire new skills that their community needs. And whether those skills are in emergency medicine or obstetrical care or addictions medicine, having a funded program that would enable doctors to go from their community to train and return to community to apply those new skills in service to the needs of their patients is an important initiative that we believe will help to retain doctors and also recruit new doctors to this important work. Finally, I'll simply say that although these are three initiatives that are important for rural and Northern Ontario, everything that we're talking about today, from family physicians to the importance of keeping emergency departments open, to the importance of decreasing wait times for surgical and diagnostic imaging services, all of these are also profoundly important for citizens in Northern Ontario. I'll pass it back to you, Dr. Nowak.
Thank you, Dr. Newbery. And again, thank you to Dr. Park, Dr. Karlinsky, and all for sharing your stories and solutions to getting our healthcare system back on track. Before I turn it over to you, our members of the media, for questions, I would like to share a few words about our recommendations for health human resources and also for digital health and innovation. We know healthcare needs talented and dedicated people. And right now, the folks behind the scenes, doctors, health professionals, are holding together a system and the system is not really working for patients and not working for health professionals. And that's why we need a health human resources strategy that actually ensures everyone has access to a doctor, and we're supported in doing this work. The province needs to keep those who are practicing now until retirement, and they also have to attract new doctors to every area of Ontario to meet the needs of our communities. Funding needs to keep pace with the economic realities of practice, and the province has to make sure funding is there so that Ontario is a place where physicians want to practice and where we want to spend our careers caring for patients. We need investment for more medical learning to make sure the next generation of doctors is ready to care for us in the decades to come. And if we want to be seen here in this province as a leader in education, in our healthcare system, we have to have confidence in our own citizens that our learners have the best educators and instruction possible, and they want to stay in this province. And we have to invest in these programs like Dr. Newbery shared. We need more efficient routes for those who have been educated in medical schools around the world to start a practice here in Ontario. We also have to embrace digital health and innovation. And embracing technology will let us, as doctors, focus on patient care. And we're already seeing tools like artificial intelligence, AI scribe, decreasing the amount of administrative work that we're spending and allowing us to focus on the care. But we need funding to allow these innovations to spread and scale and result in decreased lengths in hospital stay, improved outcomes, and then also lower costs to the healthcare system. Right now, doctors are leading the charge. We're researching and implementing these new approaches, but we're doing so without adequate funding. So we need rapid assessment of these technologies and then also urgent funding so that these innovations and how we practice can become a reality and how we care for patients right away. So without further ado, I'm going to open it up to our Q&A session. For those of us joining here today, please put your questions here in the chat for any of our panelists directly or in general. And I'm going to turn it over to our team member at the Ontario Medical Association, Jordan Kerbel, who will moderate this portion of today's session. Thank you very much.
Thanks, Dr. Nowak. Hi, everyone. My name is Jordan Kerbel. I'm the Director of Media Relations at the OMA. Just want to take an opportunity to say thank you to everyone for attending, to remind you that you can put your questions in the Q&A chat. Please include your name in the media outlet if possible. We will do our best to get to every question. You should have all received the corresponding press release by now, which includes the recent polling that is going to be on your screen right now that also signifies Ontarians' concerns for the future of the healthcare in the province. But there's also a link to our press release, a link to our website, which is stopthehealthcrisis.ca. Again, stopthehealthcrisis.ca. On that website, you will find a wealth of information that may assist you in your storytelling. So you'll find the priorities and the solutions that we discussed here today. There is a lot of data and analysis on that website. There are both patient stories and physician stories, both in written and video format. All of this information, including the videos, are there for you to use or not use at your discretion. So please feel free to take advantage of anything that you see on this website. If you would like to arrange interviews separately with any of the patients or any of the physicians that you see in these videos, please reach out to us, media@oma.org. Again, media@oma.org. We will help to arrange these interviews. Almost all of them have agreed to speak to the media. Okay, now let's begin by getting to your questions. First question from Len Gilly. Nawsum University has been working hard to find ways to encourage physicians to stay in Northern Ontario when they have completed residency. Is there more that Nawsum should be doing? This is Len Gillis at thesudbury.com. Dr. Newbery, I'll throw that over to you.
Thanks so much, Jordan, and thanks for the question, Len. I think this is a really important question, and I'll highlight that there are many things, in fact, that Nawsum University is doing, and that the majority of our graduates do stay in Northern Ontario for their careers. As you may know, we are embarking on expansion to increase the number of learners at the undergraduate level who do their MD degree training here in Northern Ontario. To your point, we work hard with our residents to encourage them to embrace a career in Northern Ontario. And in addition, Nawsum University is supporting clinicians like me who live and work in small places to develop academic careers as well as clinical teachers and to some extent as researchers. And there is a really important body of work that Nawsum University does in that regard. I think one of the pieces that we're really keenly aware of is that as we train learners at the undergraduate and the postgraduate level, what we want is to be able to have contracts and work environments across Northern Ontario which are attractive to them, to which they can aspire. We want our work environments to be really welcoming. And that's not work specifically that Nawsum University can do. That's work that the government and the OMA work towards with negotiations for the contracts, and that communities need to do to help to ensure that our settings are attractive. But Nawsum's approach to engaging with communities is an important part of that as well. Thanks for the question, Lynn.
Thank you, Dr. Newbery. I believe we have another one here for you now. This is from Sarah Law at CBC Thunder Bay. Sarah Law, CBC Thunder Bay asks, what kind of tangible actions do you want to see from the provincial government to address the gaps in healthcare services in Northern Ontario, specifically with what we're seeing in Kenora Rainy River area with the departure of the Rainy River Physician Group?
Yeah, thanks so much, Sarah, for this question. This is a really important question, and I think there are many eyes on the Rainy River experience, particularly because we know that many of our rural communities are in quite a precarious situation, and as the OMA has labeled this, stop the crisis. We want to stop other communities from entering into the kind of crisis that Rainy River is currently experiencing with their physician workforce. I think there are several things that the government can do, but one of the things that we pointed to in the comments earlier is that we need to be creating initiatives that can support and sustain physicians. To some extent, that's going to be about the contracts that pay them for their work in their clinics as family doctors and in their emerge departments, also where they work as family physicians in the community. But we know that there are several things that are done in other jurisdictions, like British Columbia, through the Rural Care Coordination Center, that create initiatives that can help to support and sustain physicians in the work that they do through education initiatives, through locum supports, through opportunities to retrain and maintain their skills. And so that is one of the very tangible asks of government at this point, is to develop those resources that can help to make the work easier to sustain for physicians in small places like Rainy River.
Thank you, Dr. Newbery. The next question, Dr. Park, this one will come over to you. With emergency department closures becoming more common in rural areas, what measures are needed to ensure that emergency rooms remain open, especially in communities relying on family doctors to keep them operational?
Yeah, thanks for the question. Obviously in rural communities, this is a real challenge. For those of you that don't know, oftentimes your rural emergency doctor is your family doctor, is your inpatient doctor, is the one delivering babies, is kind of the jack of all trades. And so the pressure on them to support their emergency departments is obviously something they feel duty bound to by their communities, but it can be extremely challenging because of the pressures that they face in other areas of the system of their practice. So this is really important. I'd say a couple of things. Number one is data is always going to be king. And what's really important is that we understand what the actual workload is for these communities and how we best support them. But then B, how do we predict when they're going to need more human resource support, and how do we do that in the most effective way? So one of the things that we're proposing is a roster of emergency physicians, particularly those that are more regionally bound to an area, that can help support those rural areas when they have vacancies in their emergency department coverage. I think that that's going to be something that's going to really help them locally, but also provide that a bit more of a team collaborative approach to regional healthcare in rural areas. Similar to how, if you're in school and your teacher doesn't show up that day, then you have a substitute. It's kind of that roster situation. I think that emergency departments are going to need some support in that regard too. But it is also about understanding what their needs are, when they're going to need coverage, and how we support them in doing so. So I think all three are going to be really important.
Thank you, Dr. Park. Dr. Newbery, we have another one here for you. The intent of the Northern Ontario Medical School was to attract new physicians to Northern Ontario. There is a concern that new physicians are being trained here but leaving to work in Southern Ontario. Is the school working, or is there something that needs to be for a rethink?
Thanks so much for that question, Randy. I think this is a really important question, and it is laser focus for the Northern Ontario School of Medicine University, absolutely. So we know that more than 50% of our undergraduates stay in Northern Ontario for future work, and we know that more than 60% of our postgraduate trainees also stay. We know that when undergraduate learners go and train and undertake their postgraduate training, so their postgraduate training means they're training to become a family doctor or a surgeon or an internist or a pediatrician. It's that point in time when training kind of differentiates us as doctors. That's a very particular time of life. People are often starting families at that time of life. They may meet a partner or spouse who is from a different area where they undertake their training, and often then people put down those roots and they stay. That's part of a normal part of life, actually. And I think it's not necessarily a sign that the Northern Ontario School of Medicine University is not working. It's simply the way in which life evolves for many people who do their training. Certainly, we want to attract as many of those postgraduate trainees to come back to Northern Ontario as we can, and we have elective streams to help to do that and to bring those trainees back. But we do feel very proud of the 60% of our postgraduate trainees who stay, and the more than 50% of our undergraduate trainees who stay and live and work in Northern Ontario.
Thank you, Dr. Newbery. Dr. Karlinsky, you wanted to add something to this question.
Thanks. So I did want to highlight that not only are we having real crisis in finding locums for our colleagues in the north and within our emergency departments across the province, but you're also having a locum crisis within regular office practices across the province, whether that be in the GTA for primary care or specialists, or in any other community across the province. The workforce has shrunk and is no longer able to supply the needs so that doctors can take relief, take time off to be sick, take time off, to refresh, learn some new skills. And the retirement crisis is upon us as well. You see from the panelists, there are a couple of us who ought to be very close to retirement. But if I should retire, and I am of an age where most people would be considering retirement, I'm going to orphan 1,400 patients. So that means my practice will probably have tremendous difficulty in finding a new family doctor. I don't have the conscience to do that. And as long as I can keep working, I will keep working. But wouldn't it be great if we had that health human resource plan that could allow for the pipeline to increase? And that means offering team-based care, offering supports to run small businesses, making family medicine good work again, which it hasn't been for quite a long time.
Thank you, Dr. Karlinsky. The next I'm going to go to is Justin Chandlers with CBC Hamilton. Locally, I'm hearing concerns about long wait times for diagnostic imaging, notably MRIs and CT scans. What can we do to bring down those wait times? Dr. Nowak, I'll throw that over to you.
Thanks, Jordan. Thank you, Justin, for this question. I'm a family doctor myself. I know when family doctors, physicians struggle to get diagnostic imaging for our patients. I think of many people in my care over the last few months, it leads to delayed diagnosis, delayed things like cancer diagnostics and treatment as well. And it actually harms people when they're waiting, when people are languishing on wait lists for tests, when we as doctors can't get the tests that we need to care for our patients. That has a big ripple effect on our healthcare system, leading to harm to patients and then also increasing costs as we're getting treatment to people much later on in their course. And that's why a big deal from this government would be something like centralized referrals, right? So centralized referrals, imagine a world where if you need access to, let's say it's a test or even a specialist from your doctor can send that request into the system. Let's say maybe you could drive up to 50 kilometers. Maybe you can't. Maybe you rely on public transportation. You can note that. Maybe you want a specific place or hospital or surgeon or doctor. You could list that. Or maybe you really just want someone who's available as soon as you can. And you could specify the urgency. That would be a low-hanging fruit for the province to really take on, to tackle both specialist wait times and then also diagnostic. So centralized referrals would be a big deal for those wait times and for the administrative burden that we face as doctors. Good for patients, good for doctors, and good for healthcare system as well.
Sorry, Dr. Karlinsky, you had something you wanted to add.
Sorry, I noticed in the chat, Randy, you asked if we could elaborate more on the team approach and what do we mean at the OMA about that. So teams can be a variety of organic or inorganic groups of practitioners. So for me, a team would include a nurse, perhaps a nurse practitioner, physician assistants, very highly trained, skilled medical office administrative staff, perhaps it could include social work, physiotherapists, but everybody working in concert together to provide the necessary care that each and every patient needs and deserves. Without that kind of team, we have an inequity across the province where there are about a third of patients receiving primary care in a team-based model, and the other 2/3, as I call the have-nots, who may be cared for by a single physician or 2 physicians working in an office with no access to those same supports. And that's an urgent crisis. Each patient should be wrapped around in care by the appropriate team so that they can get what they need locally from their family doctor's office.
Thank you, Dr. Karlinsky. Dr. Newbery, another follow-up for you from Sarah Law. Everyone, we will get to all the questions, so thank you. Sarah asks, what kind of support do you want to see to improve access to doctors and healthcare services within remote First Nations and support to prevent burnout among physicians serving these communities? Again, that's Sarah Law, CBC Thunder Bay. Dr. Newbery, thank you.
Yeah, thanks so much, Sarah, for that question. I think this is a really important question. And as you know, the needs of remote First Nations communities in Northern Ontario are very high. We have 30 remote fly-in Indigenous communities in Northern Ontario. And the physicians who serve those communities work very hard to provide the best care that they can, often in very difficult circumstances, and often supported only by 1 or 2 nurses who might live in the community year-round. And kudos to the nurses who are there providing really terrific care. I think one of the things that we are very aware of is that often these are populations that have some of the most limited access to team-based care. They might benefit significantly from access to physiotherapy or occupational therapy or wound care nursing and really struggle to be able to access that. And we know that one of the things that many family physicians who live or work and provide service to these communities would benefit from is access to the same kind of team-based care that we're talking about for every other citizen of Ontario. Just has to be delivered in a different way in a remote community. There are challenges for housing healthcare teams when they go to remote First Nations communities, and there's important work to be done intergovernmentally between Health Canada and our provincial government services to ensure that access to care is seamless for citizens who live in remote First Nations communities. To the question of burnout, I think team-based care is an important piece. We also know that there is a particular burden of paperwork for people who serve Indigenous communities, particularly when it comes to some of the stipulations of NIHB. And the paperwork burden that comes with that is substantial, and there's important work being done to advocate around that as well.
Thank you, Dr. Newbery. I'm going to throw the next question over to Dr. Park and then Dr. Karlinsky for follow-up. This is a follow-up from Justin, CBC Hamilton. I'm also wondering, how do long waits for imaging affect overall patient care across the system? Dr. Park, let's start with you.
Thanks for the question, Justin. I would say I would approach this question in a couple of ways. Number one is to look at the macro of the system, and the other part is to look at the micro. So let's start with the micro, the patient experience. Imagine you need an imaging test or you need some procedure, and I think this goes across both, and are waiting for a really long time for that. A couple of things happen. Let's say it's something like you need a hip or you need a knee, or you need the relevant imaging that goes along with that. Those place a lot of burdens on the patient individually. They are in great distress, anxiety, pain, concern about what could be going on with their body. That changes them physiologically, that changes them from a mental health standpoint. And there's no world in which we live in where people are saying, you know, there could be something wrong with you, wait longer than you think you ought to have, and that doesn't affect you as an individual. And you know, that places a great strain on them, their relationships, their own well-being. So that's the micro perspective. From the macro perspective, what I would say is, I don't know a lot of like chronic diseases that get better when you just leave, right? So this idea that, well, you can wait longer. Well, what happens is that, again, as I said off the top, is that patients get sicker. Their diseases become more complex. And as their disease becomes more advanced, it doesn't become easier to treat. You know, I have this philosophy, this saying kind of that you either pay now or you pay later. And when you pay later, it's always going to be more expensive. It's going to be more costly. And I don't just mean dollars-wise. I mean impact to both the patient, to the system, to the physicians and healthcare professionals that are treating them. And so that's kind of the way I see it, both from the macro and the micro. of understanding what long wait times can do to patients. Dr. Karlinsky?
Yeah, I agree with everything that you've said, Dr. Park. And the lived experience here at the coalface, as I like to call my office, is the patient's anxious, they have a need, the test is not happening in a timely fashion. Often myself and my staff are calling around 3, 4, 5 different specialists or different diagnostic imaging centers. There's no central referral basis, so we're getting rejected. People will say, this specialist can't see you in a timely fashion. Please try another specialist. All of this is very wasted, inefficient use of time. Meanwhile, the patient at the center of this issue is, suffering. And as Dr. Park said, the suffering may be exclusively physical, but seldom is it exclusively physical. There's the anxiety, there's the loss of productivity, there's the loss of being able to participate, in a good quality of life with family and friends. There's managing their chronic pain, which becomes more and more unstable and difficult to treat. And so the ripple effect is just, as Dr. Park said, more costly and definitely more concerning for everyone, the patient at the center, their family, their employer, and obviously myself and our entire staff who are advocates for each and every one of you. This is untenable. It has to be solved.
Thank you, Dr. Park. Dr. Karlinsky. Dr. Newbery, we have another one for you. This is from Ryan Drury at CKNX News in Wingham, Ontario. Here in Midwestern Ontario, we've seen numerous emergency department closures in all of our major hospitals in the area. In Chelsea, the emergency department is outright closed due to staffing challenges. What does the government need to do in concert with educational environments to ensure that we have more nurses and doctors coming through the pipeline to staff these emergency departments?
So thanks very much, Ryan. I think this is a really a very top of mind question for everybody who has an emergency department that is at risk of closure. And certainly, I think the Chesley experience has been a really important one for us to be aware of. I think there are several things that can be done, some of which are being done actually currently. And I think, looking at how we expand opportunities for internationally educated healthcare providers, both physicians and nurses, to be able to enter into the province of Ontario and be licensed to provide care and become part of a team that makes a commitment to a community is an important piece. I think we do need to move away from an itinerant workforce, agency nursing in particular, and we can't be locum dependent in our settings. That doesn't lead to high quality care. It helps us keep the doors open, but we can't build great team-based care for communities on an itinerant workforce. So supporting internationally educated healthcare providers to come into Ontario to license and to make a commitment to a community is important. I think the government has opportunities to support municipalities, to welcome newcomers well, so that those new to community healthcare providers feel like they belong to that community and in that community and can be retained. The third thing that I'll say is I think there is a lot of work being done right now to expand nursing programs and to expand seats in medical school and in postgraduate or residency training programs. And that is really important work. But it will only be successful if we retain the clinical teachers, both physician clinical teachers and nursing teachers in our communities, and in communities like Chesley, Wingham, Marathon, Chapleau, Wawa, the places where we actually need these trainees to go and work in the future. If we can retain our teachers and demonstrate the opportunity to live and learn and work in communities like yours and like mine, then we stand a chance of the success of the expansion of nursing programs and medical school programs for our future workforce. And I think that that's a really important piece that we often overlook when we talk about education expansion.
Thank you, Dr. Newbery. We've had a follow-up question for you from Lindsay Alec from CTV Sudbury. Dr. Newbery, could you further expand on your comments that people in the north having 2 to 2.5 year health outcomes compared to the rest of the province? I assume that means worse health outcomes. What can be done to improve that? Thank you.
Yeah, thanks so much for that question, Lindsay. And I'll say that this data is data that came through Health Quality Ontario a few years ago. And they really did look at the provincial averages around life expectancy, and then specifically in the northeast and the northwest of the province. This is a complex issue, but there are a couple of things that I think are worth highlighting. The first is complex chronic disease and respiratory or lung-related diseases and cardiovascular, heart and blood vessel diseases in particular. We know that in Northern Ontario, there is a four-fold greater rate of lower limb amputation than there is in the rest of the province. And that is a marker of the burden of diabetes and cardiovascular disease, and of the challenges of access to care for management of those chronic diseases and management of wounds. So we know that the challenge of access to healthcare impacts life expectancy when it comes to management of those chronic diseases. The second thing that I'll highlight, and I think this is a really important issue in Northern Ontario, is that the 5 cities with the highest opioid death rates in the province of Ontario are Thunder Bay, Sudbury, Sault Ste. Marie, North Bay, and Timmins. They are the 5 urban sites that I referenced. 6 of the 7 public health units with the highest opioid death rates in the province are 6 of the 7 health units in Northern Ontario. So that we are losing people at very early stages of their lives as young adults or middle-aged citizens. And we need a much more robust approach to managing mental health and addictions. And that's going to require health care provider resources to support citizens who are struggling with opioid addictions issues. Management of chronic disease, management of mental health and addictions issues, and improving access to care overall for citizens of Northern Ontario, I think are 3 of the things that we can do to decrease the gap in life expectancy that currently exists for citizens of Northern Ontario.
Thank you, Dr. Newbery. The next question is from Megan Olive, health reporter at the Toronto Star. The OMA has been campaigning for years now to reduce the burden of paperwork for its members. You say the weekly hours of paperwork burden for your members remain at 19.5 hours per week. At the same time, the Ministry of Health has worked to reduce the burden with several initiatives, including working with the OMA to streamline 12 key government forms. The ministry says these initiatives will reduce paperwork burden by 95,000 hours. Why has there not been an improvement in paperwork burden despite your campaign and the ministry's efforts? Dr. Nowak, I'll throw that over to you.
Listen, we need to see some more ambition from this government on healthcare. We have a population that's getting sicker, older, that needs more care. That means the administrative burden is ballooning along the way. And what people expect is a healthcare system that works. And doctors, we signed up to care for patients, not fill out forms and try to navigate the bureaucracy of our healthcare system. We saw numerous examples of that from Dr. Karlinsky, Dr. Newbery, Dr. Park, where doctors are just trying to get people the care that they need. That's a part of that administrative burden. And what I will say is that this healthcare can be a legacy defining moment for this government. On one hand, this can be the government that, let healthcare, that watched healthcare become a catastrophe, right? Sure, it's due to chronic underfunding in our healthcare system and through successive governments, but we need a government that owns the challenge that we face now. So that's on one hand. On the other hand, this can be the government that finds everyone a family doctor, that deals with our emergency department closures, that deals with wait times and gets people the care that they need. So this is one of those places where people, Ontarians, we need ambition from our government to tackle the challenges that are facing our healthcare system.
Thank you, Dr. Nowak. Dr. Park, this question is for you. Can you expand on the issue of patients' needs being more complex?
Yeah, so we talked about it a little bit in terms of wait times and lack of access to a family doctor, and I'll kind of coalesce this with one of the other questions about what is causing this. Is this caused from COVID backlog? Certainly we had this issue for, as Dr. Nowak just said, we've had this issue for decades. This is not a today issue. This is a reflection of what happens when millions of Ontarians don't have a family doctor. We've gotten there. Every one of the colleagues on this panel that is a family doctor or knows a family doctor or is related to a family doctor has had patients coming to them daily to say, can you take my family's babysitters, dog sitters, whatever. Any person that's even by any degree related to somebody we're being asked to take these patients on. And so that tells you that there's just so many Ontarians without a family doctor, and this is not new, right? So then you combine that with a once in a lifetime pandemic that forces us as a medical community to focus on the sickest of the sick. And what that does is it creates backlogs. We're millions and millions and millions of both procedures as well as diagnostic procedures behind once we came out of that pandemic as a result of it. And so that places a tremendous amount of burden on the system. But we keep talking about the system, the healthcare system. But what we have to keep remembering is that these are patients. These are real patients with real lives that are really impacted by the burdens of not having had a family doctor for decades. And I think that that's really important to remember. We also do have a demographics curve that is aging. And when you age, your needs become that much more complex and that much more numerous. And so I think it's a confluence of a lot of these things that have led us to the complexity that we're seeing today.
Thank you, Dr. Park. Dr. Karlinsky, this question will be for you. So many practicing family doctors plan to retire soon. What action should the government take to attract new graduates to family medicine and retain those already practicing?
That's an excellent and difficult question to answer. So starting in 2015, we saw the closure of managed entry into family health organizations by that government. And Doctors Newbery and I watched at least 6 cohorts of our trainees turn away from the practice of full scope longitudinal medicine. And those thousands of graduates are not coming back. So we need to do a lot better in terms of attracting our current graduates to adopt full scope family medicine. And the only way that I believe that we will succeed is if we embrace the concept of every patient has a team. Every team is led by a family doctor. Every team is designed by those family doctors and the ancillary healthcare members that are supporting that team, and that they are properly funded so that these are good jobs and that they are supported so that everybody is working top of scope, that people with medical training are not doing paperwork 19 plus hours a day. And that's just the start of it. There are technologies, as somebody else has asked in the chat, that are very useful. But again, these technologies are subsidized or funded by us at the front lines in our small businesses. And each and every advance funded by the small business owner of your clinic takes away from something else that they can't do. And access to care is important, as we see. Millions of patients scrambling to get a family doctor to improve their health outcomes. We can do better, and we must do better. It starts with funding.
Thank you, Dr. Karlinsky. We've got a question here from Sinead Dougal at the Trillium. This is a long question. So on surgical diagnostic waitlists, we recently got some Ontario Health data showing that for the past 4 years in Ontario, 10% of children needing non-emergency surgery have waited more than 230 days for their procedures, and that around 30% of non-emergency pediatric surgeries were not completed within the recommended timeframe. The government has said it's putting $330 million more each year for children's health services, including for surgeries. Could someone comment on these numbers? And do you think that is enough? And what is the impact of these waits? I guess we're talking about surgical wait time, so I'm going to start with Dr. Park.
Yeah, so I'm going to talk about the impact of the waits first off.
Thank you.
We see a lot of kids who have chronic otitis media or inner ear infections. Antibiotics usually does a great job, but for those that have multiple in a year and require tubes to drain their ears, This is a big weight because a lot of language development is occurring in these kindergarten children. They can't hear what their teachers are saying, so they're going to become delayed in their learning processes. And so do that for 230 days to somebody who's in junior kindergarten. And this is just one example. This is a very small example of what I would term as an elective surgery that has real world impacts on these patients, particularly our children. So $330 million, absolutely, that's a welcome. There's no amount of money that we'll say that is not welcome and injected into the system. And what we need to ensure, and what we've been talking about really at the heart of what Drs. Nowak, Karlinsky, Newbery, myself have been urging and saying is that this is about access. You know, in a word, this is about our patients getting access to the care that they need, when they need it, and where they need it. And time will tell. Certainly $330 million is a lot of money. But what we need to ensure is that those patients are getting it in a timely fashion so that it does not create downstream issues for these children as they become, older children and eventually adults. So, time will tell, and it's going to be really important to keep following up as to how we are hitting our targets.
Okay, thank you, Dr. Park. We're going to have time for one more question, and everyone, I would encourage you, and I'm sorry that we're not getting to all of them. There's been a lot of questions coming in. You can always email them to us at oma.org, and we'll get answers for you. The last question is going to be for the CTV. It's actually quite a long question. Dr. Dominik Nowak, what are the current number of Ontarians who do not have a family physician in the GTA? How does this compare with the rural Ontario? And is the numbers of people in the GTA without a doctor growing? And is it considered a crisis in the GTA, or are we already on our way there? I know there's a lot of asks for numbers there, but I think the emphasis of the question is in the crisis in family medicine. But if we could start with the number of people in Ontario that don't have a family doctor.
Oh, we're already in crisis and catastrophe levels all across the province. Communities in the north, rural communities, remote communities are especially hard hit. But I'm hearing from communities all across Ontario that they can't find a family doctor. People can't get the care they need. Folks are languishing on wait lists for far too long. Right now, nearly 1 in 4 people in this province can't find a family doctor. And in many communities that I'm speaking to, that's almost 1 in 2 people or more, where they've had a string of retirements, they're having difficulty recruiting, they're dealing with this Hunger Games of just trying to bring doctors into their communities. That's unacceptable. And that's why we're calling this a crisis, more than a crisis, a catastrophe that's already happening. It's already impacting patients. The state of our healthcare system is already harming patients. And as health professionals, as doctors, we're saying enough is enough. And we're calling on government to get things back on track. We're calling on government to not just have some ambition in healthcare, but restore that foundation that people can rely on in their healthcare system and to rebuild confidence in a healthcare system that we used to be proud of. Right. And I know we can get there, but it'll take ambition and action from this government to get to a place where people can rely on their healthcare system again.
Thank you, Dr. Nowak. If I may throw it to you just for some final words.
Yeah, I do want to emphasize the importance of what we're talking about here. Everyone here, all of you joining us, you're here because you believe our healthcare system can be one that we're proud of again, can be one that works for people again, where we can find everybody a family doctor, where people can get the care that they need in emergency rooms and diagnostics, in specialist offices and home care, all of these different places. And it can be a place where we get things back on track. That's why we're calling out the crisis that we're in. That's why we're calling in the places that are in catastrophe. But it's going to take commitment from this government to build back towards a system that works for people. So thank you for being part